Now today, well into the 21st century, medicine is broken. Medicine today can be described as a pill for every ill, where doctors like myself impersonate walking prescription pads. Massive amounts of drugs are being prescribed. Did you know that in Northern Ireland, the average person gets 21 prescriptions every year? Just how sick the population is difficult to comprehend. It's no exaggeration to say that the number of healthy people is vastly outnumbered by the metabolically unwell. The US National Survey examined adults on 5 metabolic health markers and found that only 12% could be considered healthy. And the problem was even worse for the over 60s, with only 2% considered healthy. It's now even predicted that the average child born in America today will not live as long as his or her parents. And one of the major problems with this pill for every ill approach is that drugs are more often used as a band-aid for symptoms rather than to address the root cause of disease. All too often, these drugs have what are called euphemistically off-target or unintended effects. 2 of the top 10 drugs prescribed in Australia today, for example, pantoprazole and esomeprazole, are drugs for reflux. And when I was in medical school, I was taught that these were incredibly good drugs with an excellent safety profile. Even ongoing, indefinite use was not discouraged. Of course, they're not that benign. Proton pump inhibitors can impair the absorption of several key nutrients, including B12, calcium, magnesium, zinc, and iron. And quite predictably, they've been linked to increased fracture risk, dementia, pneumonia, gut infections, and even diabetes. Add to that the suggestion that they cause excess mortality due to cardiovascular disease, kidney disease, and cancer, and you might ask why they're amongst the most commonly prescribed drugs. And one of the reasons is that once you start them, they're hard to stop. This is due to something called rebound acid hypersecretion. Basically, when they're stopped suddenly, an exacerbation of reflux symptoms commonly occurs, and this makes people think that they still need the drug. This has even been shown in healthy volunteers, where 44% of them experienced this phenomena. Let's now have a striking look at an example of band-aid medicine. A pill for every ill in action, and it should shock you. It began when this 71-year-old lady was found by her family doctor to have high blood pressure, so she was started on a drug called amlodipine. Now, one of the known side effects of this drug is swelling of the legs, which she, of course, developed. So 3 weeks later, she attended a cardiologist who, on noting this new development of leg swelling, prescribed 2 diuretic medications, which both cause dehydration. Basically, they make the kidneys excrete extra fluid into the urine. It then just so happened that this lady started urinating a lot. So much so that another 3 weeks later, a urologist diagnosed her with an overactive bladder and prescribed her another drug, physiotherapy, to treat it. This is all true. The problem was this drug caused the side effect of a dry mouth, and so she went back to her family doctor with this new complaint. You know where this is going. And true to form, her family doctor prescribed another drug, anethol trithione, for this new complaint. At this point, this 71-year-old lady was on 17 different drugs, taking them up to 3 times a day, 5 of them having been commenced in rapid succession. And shortly afterwards, she lost her balance and fell, striking her head on a bathtub and fracturing several bones. Now, is it significant that at least 7 of the drugs she was on are associated with an increased risk of falls? So then, if Band-Aid medicine doesn't work, What about the drugs we prescribe to prevent disease? You know, like statins, which hold spots 1 and 2 of the top 10 drugs prescribed in Australia today. Well, the problem is that statins were developed to reduce the level of LDL cholesterol, which is a surrogate marker which is thought to reliably associate with heart disease. The problem is many surrogate markers, including LDL, don't do what it says on the packet. LDL, in fact, is not the major cause of heart disease. This study of patients hospitalised with heart disease, for example, found that only 23% of patients had high levels of LDL. Consider this systematic review, which analysed 19 prospective cohort studies with over 68,000 participants. It found that the individuals with the highest LDL levels tended to live the longest. In fact, 16 of the 19 studies found this relationship. The higher the LDL, the lower the chance of death. Even studies which excluded subjects with terminal disease, heart disease, and diabetes found that those with the highest LDL levels had a 50% less chance of dying than those with the lowest LDL levels. This effectively eliminates reverse causality from the equation, and these findings are robust. Which is probably why this meta-analysis found that statins offer no mortality benefit in a primary prevention population. That is, taking a statin does not reduce your chance of death if you don't yet have heart disease. In fact, 7 of the 8 eligible randomised controlled trials came to this conclusion. And the outlier study has serious methodological flaws that have been extensively documented in the literature. There is, however, some evidence of mortality benefit in secondary prevention populations. That is, in people who have some heart disease. The question is, what is the magnitude of this benefit? Can anybody guess? This review paper analysed the data from 11 eligible studies comprising more than 90,000 subjects and assessed the median gain of life and found it to be just 4.1 days. And to add insult to injury, it now seems that any benefit of taking statins, however marginal, is completely unrelated to the degree of LDL lowering. This paper, for example, found that statin-taking subjects with the lowest cholesterol levels were the most likely to die. Now, there are many other drugs besides statins that have been developed on the basis of surrogate markers that have also failed, despite doing exactly what the drugs were intended to do. The very first cholesterol-lowering drug, tryperenol, brought to market in 1959, is one such example. You're looking into the eyes of a 6-year-old boy with a permanent cataract, one of the many unintended side effects of this drug, which somewhat ironically also included accelerating atherosclerosis. Another example is torcetrapib, a drug developed by Pfizer that was proven to both increase HDL and lower LDL. And according to the lipid heart hypothesis, this is the absolute holy grail of heart disease prevention. There was, however, the small problem of people dying. After 12 months on this LDL-lowering, HDL-rising drug, the death rate increased by 58%. A problem considering that Pfizer had just dropped $800 million on it. The fact is there's a long history of drugs that have been approved for specific uses based on surrogate endpoints that have been later found to increase mortality. We need to either use more clinically relevant endpoints in our research, like all-cause mortality itself, or find more reliable surrogate endpoints. Which brings us to the question, are there any reliable surrogate markers related to the diseases of modernity, the conditions which plague us today? And the answer is yes. Insulin resistance. Insulin is a hormone which normally circulates around our body in the bloodstream and is essential for life. But sometimes the insulin we have doesn't work as well as it should, in which case we're said to be insulin resistant. So to compensate for this resistance, our pancreas releases more insulin, resulting in higher levels of insulin, which can easily be detected on blood tests. Insulin resistance has been convincingly shown to be involved in the pathogenesis of many of the top 10 causes of death in Australia today. This study divided subjects into 3 groupings based on their level of insulin resistance and then followed them for 6 years. In those subjects who were the least insulin resistant, on the left, there was not one recorded clinical event over the 6-year period. Contrast this with those with insulin resistance on the right, who from the top down developed cerebrovascular disease or stroke, type 2 diabetes, coronary heart disease, cancer, and hypertension. The results are absolutely striking. And equally striking is this research on obesity, a visible physical indicator of metabolic disease. This study found that the 25% of subjects with the lowest insulin levels, shown on the left, had a 2% chance of becoming obese over 8 years. Can you predict what the risk was for the 25% of subjects with the highest insulin levels? 36 times greater at 72%. For more evidence that insulin is causally associated with obesity, consider this picture of a 34-year-old female who had a tumour that produced excess insulin. Here she is, 107 kilograms. She then had surgery to remove the tumour, which led to a drop in her insulin levels. The result being that over the next 50 days, she lost 18 kilograms without any changes in her diet. Of course, anyone who has ever injected insulin can tell you it causes fat gain. This is a localised accumulation of fat in someone who habitually injected insulin into 2 sites into their lower abdomen. So let's take a closer look at the mechanisms by which insulin promotes fat storage. The first point to note is that fat cells, known as adipocytes, are in contact with the circulation, which means different molecules may enter or leave a fat cell by the blood. The 2 molecules we're most interested in are triglycerides and glucose. It's the action of insulin that leads to both these being stored inside fat cells. In their complete form, triglycerides can't enter fat cells. However, under the influence of insulin, the enzyme lipoprotein lipase activates and cleaves this larger molecule into a single glycerol molecule and 3 fatty acids. The fatty acids can then diffuse into the fat cell. The glycerol can then be converted into glucose by the liver in a process known as gluconeogenesis, which then also enters the fat cell when insulin activates the GLUT4 transporter. And once inside the fat cell, the glycerol is converted back into glucose, they combine together, and now you have fat being stored, all under the action of insulin. But insulin doesn't just stuff adipocytes full of triglycerides. It also blocks the triglyceride from leaving. To metabolize a burned fat, the triglyceride must clearly leave the fat cell. The triglyceride has to be cleaved before this can happen. And this occurs under the action of the enzyme hormone-sensitive lipase, which just so happens to be blocked by insulin. Without this step, the triglyceride cannot leave to be metabolized. So putting it all together, insulin allows fatty acids and glucose to enter fat cells and then prevents their leaving. Insulin is quite literally the hormone of obesity. Of course, understanding how insulin causes obesity doesn't help us if we can't do anything about it. But we can. And one of the ways is by limiting the carbohydrates in our diet. This is because carbs lead to increases in the blood levels of glucose, triglycerides, and insulin, all the ingredients needed for fat storage. First of all, complex or starchy carbohydrates are quite literally made of glucose molecules, and after digestion, this glucose finds its way into your blood. Next, excess carbohydrates also cause the liver to overproduce triglycerides in a process known as de novo lipogenesis. And finally, carbohydrates potently stimulate the release of insulin, much more, in fact, than an equivalent amount of fat. This is why low-carbohydrate diets are superior to low-fat diets in terms of weight loss. Between 2003 and 2021, there were 67 randomised control trials comparing weight loss on a low-carb and a low-fat diet. Of these, 36 had statistically significant results, meaning they were unlikely to be due to random chance, the results from the other studies being less trustworthy. For each study, the green bar represents the amount of weight lost in the low-carb group, and the adjacent red bar, the amount of weight lost in the low-fat group. If you look at each pair of results, you'll see that not a single study found in favour of low-fat diets. Low-carb for the resounding win. Of course, obesity is not the only sign of metabolic disease. Perhaps the most important is elevated blood glucose. When insulin is working normally, as in when you're not insulin resistant, insulin removes most of the glucose that enters the circulation by placing it in other tissues like muscle and the liver. With insulin resistance, however, insulin does not effectively remove glucose from the circulation, resulting in a higher level of glucose in the blood. And when this gets high enough, it can be considered to be diabetes. The effect of carbohydrate intake on blood glucose levels therefore depends a lot on the state of insulin resistance. Many people can in fact consume a good amount of carbs without developing signs of metabolic sickness, such as high blood glucose. The key factor is whether or not they are insulin resistant. Once you are insulin resistant, your capacity to tolerate carbs is drastically reduced. Which brings us to the question, what are the most important factors that precipitate the development of insulin resistance in the first place? And the answer is, I believe, twofold: fructose-containing sugars and seed oils. Fructose is often referred to as fruit sugar, and it's contained in both table sugar and high fructose corn syrup. Food manufacturers, of course, are expert at hiding sugar in plain sight, and these are all pseudonyms by which sugar goes by. Now, fatty liver was once considered the domain of alcoholics. However, excess fructose consumption, be it from fruit juice or candy, is more than capable of causing this disease, and with it, insulin resistance. I'll say that again. Excess fructose, by way of damaging the liver, causes insulin resistance, which you know is a major cause of modern disease. This study demonstrated the clear impact of fructose on the liver by reducing its consumption. So 41 children with a habitual high fructose intake had their diets manipulated so that the total energy intake remained the same, but the amount of energy from fructose reduced from 12% to 4%. And after just 9 days, median liver fat levels had reduced by 47%. Let me say that again. After just 9 days, the median liver fat had reduced by 47%. Which was also accompanied by big improvements in insulin levels. Here's the thing though, as bad as carbs and sugar might be for our health, seed oils could be even worse. The consumption of seed oils began to rise in the early 1900s, which was well timed to have a causal role in the heart disease epidemic. Furthermore, 3 large-scale randomised controlled trials, the gold standard of research, have found that replacing saturated fats in the diet with seed oils leads to a significant increase in mortality. And to my knowledge, there is no other equivalent study that shows otherwise. This paper from the British Medical Journal found that a seed oil intake exceeding 6% of total energy likely increased mortality by more than that of high-carb diets. The thing is, the average Australian consumes far more seed oil than 6%, more than double in fact, at about 13%. You can see the potential for harm. This paper from 1965 details the impact of seed oil intake on 2 subjects who were ultimately removed from the study with diabetes. One subject developed glucose in the urine, which typically only occurs when blood levels are quite high. The seed oil was then stopped and the glucose disappeared from the urine. The oil was then resumed again, at which point the glucose returned, after which point it was finally stopped. The other subject was also noted to have diabetes, which was diagnosed on a glucose tolerance test only a few weeks after commencing the oil. I think this is a bit of a hidden iceberg. There's very little visibility about the potential impacts on seed oils, insulin resistance and diabetes. And one of the reasons seed oils do contribute to insulin resistance and elevated glucose is because their polyunsaturated chemical structure contains unstable bonds which are prone to oxidation. Grant, can you start holding your breath? Great. This study, for example, found that oxidation of walnut seed oil occurs within days. The problem is, when we ingest oxidised oil, these oxidation products enter our circulation. The more oxidised the oil, the higher the level of oxidation in our blood. And these oxidation products contribute directly to fatty liver disease and insulin resistance. The electron microscope picture here shows oxidised fats coalescing in the liver shortly after consumption. The story for oxidised oil consumption becomes even more interesting when consumed by subjects with poor blood sugar control. This graph shows the level of oxidised fats in the blood after a meal containing oxidised oil. The two left columns are for subjects with normal blood glucose, and the right column, subjects with poorly controlled diabetes. The high glucose levels in the circulation leads to significantly more oxidative stress, as you can see. And what's more, the oxidation levels were elevated for 9 times longer. In the subjects with normal blood glucose, the oxidation was cleared in 8 hours. In the subjects with elevated blood glucose, the oxidation products lasted for 3 days. Now let's circle back to fixing the problem of metabolic disease. Clearly the drugs aren't working, simply because they don't address the root cause of the problem, which is diet-related. So the first step is to reduce the consumption of sugars and seed oils, both of which contribute significantly to insulin resistance. And if you're already insulin resistant, you should consider drastically reducing the amount of starchy carbs you consume as well. Now, various diets actually fill this bill, promoting the avoidance of seed oils, sugars, and excessive amounts of starchy carbs. This includes low-carb diets, keto diets, and the paleo diet. And one thing they all have in common is that they've been proven to work. Much better, in fact, than drugs. This study found that a low-carb diet resulted in improvements in insulin resistance in just 4 weeks. In fact, half the participants no longer met the diagnostic criteria for metabolic syndrome. And this was after the low-carb intervention was specifically formulated to not lead to weight loss, something that's harder than it sounds given how readily people can lose weight on low-carb diets. This systematic review and meta-analysis of 13 studies on the ketogenic diet found improvement in glucose levels, triglycerides, HDL, and weight loss, all hallmarks of metabolic disease. While this systematic review looked at 10 randomised controlled diets on the paleo diet and found large improvements in insulin resistance, triglycerides, blood pressure, and inflammatory markers. Consider for a moment what would happen if we had a drug that could do all of that. Prescriptions would absolutely eclipse those of even statins, which have now made more than $1 trillion in sales. It's clear that nutritional strategies blow drug treatments out of the water when it comes to metabolic disease, which perhaps makes it a problem that more than 70% of doctors in this study received less than 2 hours of nutritional training. I'd like to leave the final word to this man, Thomas Edison, who predicted that doctors of the future would have more interest in diets than drugs. We're not there yet, but I live in hope. Thank you.